Hello, everyone, and welcome to your first lecture of Concepts 2. We're going to talk today about the prevention of medical emergencies. So, at one time, it was considered sufficient to screen your patient's health by whether or not they could walk up a flight of stairs to your office on the second floor. Apparently, it was common for dental offices to be on second floors, but now we use something called a 4-MET scale. So, if you are just sitting doing nothing, you're set to be at a 1-MET. Say you're running a marathon and you're sprinting, then you're about an 8 to 9 MET. So we look for someone right about a 4, meaning they can walk back to your room, they can sit down. That's about a 4-MET. So, what are some ways that we can help prevent an emergency in the dental setting? So, think of some things that we're already doing and ways that we can prevent or minimize the risk of an emergency. Some things you might be thinking, hopefully, vitals. Vitals are a key part of preventing an emergency. Dialogue, having that conversation back and forth, asking those follow up questions with the patient. Their medical history is another one. Taking the time to look at their medical history, making sure that it is filled out completely. But that's also another way. Um, okay, so minimizing the risk, kind of the same thing. Pre-treatment evaluation, your medical history, having that evaluation and that dialogue. When are we going to modify treatment? The most important step to prevent medical emergencies is modifying treatment. So, you're going to look at that patient. Are they sweating? Do we know the word for sweating? The word for sweating is diaphoretic. That's a word you'll see on exams and tests. You won't see the word um, sweating. Are they nervous? Um, what about um, are they shaking? All those kinds of things. Are their pupils enlarged? That can be a sign of being nervous. But who's with the patient the most? We are, as hygienists, we are with that patient the most. We are the ones that are really going to start to undercover those medical conditions. Remember that modifications to treatment could reduce an emergency. So, what are modifications, right? Stress reduction protocol. Do we think it's better to see a patient in the morning or in the afternoon? Chances are, for most patients, nervous, anxious patients, the morning is probably going to be a better time. Otherwise, if they're coming in the afternoon, they might be thinking about this appointment all day long and they might be thinking of ways that they can either not show up or cancel. So, first thing in the morning, before they really have enough time to think about it, is the best way. And then again, you're having long appointments. So this semester, if someone is really nervous and anxious, do we want to have them in the chair for 6 hours? That might be convenient for you as the clinician, not so much for our super nervous patients. You want to think more that first block in the morning, have them come in, and that's about it. And then remember, not modifying treatment could cause an emergency. So, why have emergencies increased in the dental setting? I'm not sure if anyone is familiar with this, but the number one reason, we're living longer. We are living longer lives. Life expectancy is much higher than it used to. So, medications are increasing our lifespan. So, that's one of the biggest reasons. You might have that older patient that comes in and they're at risk of postural hypotension, so they might get up too fast or they might pass out in your operatory. So what could signal the risk of a possible medical emergency? Could be anything filled out on that medical history. Do they have a heart condition? Do they have asthma, epilepsy, thyroid problems, diabetes? So again, the more questions that we ask, the more information that we're going to uncover. It used to be you would get older, you'd get sick, you would pass away. But now, with all of these advances in the pharmaceutical industry, People are living much longer. They're surviving cancer. They are controlling their chronic illnesses with medications. So keep that in mind. So again, we kind of talked about this age factor, right? Medical advances, longer dental appointments, increased use of drugs in medicine and dentistry. So again, the longer dental appointments, that is a leading factor in medical emergencies in a dental setting. So you want to think about, your conscious sedation patients, your patients that are coming in for that long cosmetic surgery. They're able to do that now. So their appointments are longer. And those longer appointments, we're more likely to see a medical emergency. So pre-treatment evaluation. So this is important. It's probably one of the most important steps in the appointment because we're wanting to know the status of the patient. Do we need a physician consultation? Do we need treatment modifications? And again, what are our treatment modifications? So, medical history. Is there any undetected conditions? What types of things are we screening for? So, in order to prevent emergencies, we want to screen for undetected medical conditions. And the best way to do that is by taking blood pressure. You want to take blood pressure because that's the number one, I believe, medical condition, undiagnosed medical condition. You got to think we're seeing patients 2 to 4 times a year. Some patients might not even be going to see their regular physician. So we want to be taking their blood pressure and screening those patients. And if we see that their blood pressure is high, they may not have any idea. So we may be referring them back to their physician. It's also really important that we keep taking the MIL because the MIL is going to give us that minimum for blood pressure. So somebody might have an extremely high blood pressure and we wouldn't know because we wouldn't have pumped the cuff high enough. So if you're only pumping it to say 150, 170, but their blood pressure is 220, you're going to miss that if we don't find the MIL first. Remember, their medical history is a legal record. It always has to be signed. The reason it's signed is because the patient is signing that this is the truth, that everything that they have put on their medical history, all of the answers to the follow-up questions that you have documented, they are signing that is correct. Okay, so reasons for physical evaluation. Again, undiagnosed, uncontrolled conditions. You're going to have patients that you're going to ask about their medical history. They're going to come in, you're going to, if you're working already in private practice and ask about their medical conditions, and they're going to say, no, nothing. I'm great. Nothing. You also might get pushback and they may say, nothing that has to do with my teeth. If you work in a dental office, I'm sure you've heard this before. Or they say, nope, nothing's wrong. The doctor comes in the room and the patient, blurts out or lets out everything. Oh, I just had a heart attack. I had 4 stents placed. And you, as the hygienist, will be standing there, with your jaw dropping to the floor because the patient, you had no idea. And that's just, it's going to happen. But the more I always like to ask patients very specific questions, any recent hospitalizations, any recent surgeries, anything that has changed since we saw you last. So sometimes once you ask that surgery question, they're more apt to give you an answer for that. I remember one time I had a patient and I asked if there had been any changes in his history and we went through some questions. Nope. I sat him back. I said, "Oh, it's been so sunny. Have you been out in the sun?" "Oh, I can't go in the sun. I just had surgery to remove skin cancer off my face about a month or so ago." So again, I thought I was doing all the right questions, but just that dialogue after with the patient, I was able to figure out some other information that was going on. And I don't really know why it is that they don't like to tell you. I don't know if they forget. I don't know if they, sometimes you'll ask, is there any changes or anything about your medical history? And they'll start telling you about a pain in their tooth. So I think as they come in, they're associating their medical history with just their mouth. So it all depends on the questions that you ask them. And anything that is circled in red, you always need to ask follow-up questions. And you might even find on the clinic floor that you might have a patient that's not comfortable with, you know, going in depth into their medical history. It might be a family member or a close friend that they may feel more comfortable telling a faculty member, and that's okay too. Sometimes we might come over, we might ask you to kind of step aside, and we might go into that dialogue a little bit more with the patient. So the minimum components of a physical evaluation, always measuring vital signs. This allows for modifications to treatment. And it also gives a baseline for comparison in an emergency. So say in the event that you have to call 911, they're going to want to know, what was this patient's blood pressure when they came in today? And then also you always want to follow up about medication. So any medication that a patient tells you that they're taking, there should be questions and follow-up questions asked. They may give you a big long list and you ask, okay, did you take these medications today? Oh, no, I haven't taken them in over a month because I can't afford them. So here are all of these medical conditions that should be treated, but they're not because unfortunately the patient can't afford their medications. So again, the more questions and the more comfortable you become with having these conversations with patients, the more information you're going to find out. And then visual inspection, how are their eyes? How are they walking, sweating? Are they fidgeting? We'll get that nervous patient, and they're going to be watching everything that you're doing, every bag that you're opening. They're sitting up to see what's going on. These are your nervous patients. You might also see them, they clutch the sides of the chair. A lot of times, too, you'll see them, they start stretching out their hands because they've been gripping the chair really, really tight. Vital signs. So, what are the guidelines? The guidelines for blood pressure are now 119 over 79. Anything above that, pre-hypertension, hypertension, etc. Pulse, right? So what are we looking for in a pulse, and the rhythm, the quality of the pulse? Are they normal? So what's normal? 60 to 100, usually around the 70 to 80 range is where we like to see the pulse. Um, Blood pressure, so the guidelines, if it's anything over 180 over 110, we will not be seeing them for treatment. I believe that that's what it is. And if it is high, we'll consult with the doctor on the floor, and then we may also need to do a medical consult. And you might have a patient and you take their blood pressure and it's 140 over 90, and it's, well, that's great for me. Like, that's really good. I took my blood pressure medication. Um, but is it good? No, not really. High blood pressure can cause all kinds of things, dementia, stroke, but also, lifestyle changes can help, but those are hard, right? It's not easy to lose weight, to diet, to exercise. So keep that in mind. These are some terms that we want to know. So PVCs, premature ventricle contractions. That is when you will have, it almost skips a beat. So that has to do with the bottom of the heart is not pumping fast enough and it's not getting the blood everywhere. So it almost feels like you're skipping a beat. Pulsus alternans is fast, is hard and slow. So it will be a soft beat, a heartbeat, a soft, hard, soft, hard. That's usually common in a patient that has congestive heart failure. Bradycardia and tachycardia. If you are familiar with these terms, Brady and tachy, you will see in a few other areas. Brady is slow and tachy is fast. Cardia has to do with the heart. So Brady cardia is a slower heartbeat. The way I like to think of that, I think of Brady, I think of Tom Brady. I think of the fact that he's retired now and he's probably slow, right? He's not as fast as he used to be. So bradycardia, slow heartbeat. Tachycardia is a fast heartbeat. So respiration. Respiration, we're going to also still be checking on the clinic floor. 14 to 20 is the normal values. This again, we're going to see bradypnea and tachypnea. Bradypnea, slow breathing. Tachy is fast. Pnea, you want to think of breathing. I like to think of sleep apnea. A means without. So think of penia as without, is sleep apnea without breathing, penia for breath. So brady and tachy. You might also see that the breathing may get, strange or different if the patient is a poorly uncontrolled diabetic. The body will start to try to get rid of the acid that is forming, and they may have some strange breathing as they're blowing off that acid. So keep that in mind. Also, when are we going to have very slow breathing? You want to think of surgery and being, under anesthesia and those opioid pain medications, as Demerol is one. But that's going to kind of have slower breathing. So that's why they want to monitor you during surgery to make sure that your breathing is all set. Visual inspection. So we're screening for any, undetected conditions, gauging those anxiety levels like we talked about before, and then determining treatment modifications. So screening for undetected conditions, do you ever see patients that might have, really enlarged ankles, or their ankles are kind of spilling over their heels? That's a sign of congestive heart failure, the swelling. You might also see their jugular veins are sticking out a little bit. What else might we see in a visual inspection? There's jaundice, that yellowing of the skin, fatty liver disease, someone that's, abused alcohol for a long time, you might see that their skin is red, may have a red nose and red cheeks. Um, Gauging anxiety, again, this is that patient that's clutching the side of the chair. They're watching everything that you're doing. Nervous fidgeting, you might see them, sometimes they're like stretching out their thumbs, they're doing all kinds of things. But we want to remember, if those anxious patients are at a very greater risk and chance of syncope. And they could be either way. They could be your anxiety patients, they could be overly talkative, or they could be extremely quiet. So you just kind of have to, ask those questions, get that conversation, that dialogue going. So again, the dialogue history, so the process of discussion. We want to attempt to determine severity of disorders and potential risks during planned treatment. All positive responses must be followed up with dialogue. So any questions that your patients answer yes on the medical history, you sign in red, and then you have a discussion about it. Ask more questions. It is going to take practice. Give yourself, grace, utilize your faculty for what are those good follow-up questions to ask. Second semester, you're really learning. By fourth semester, we're going to expect you to be doing that full dialogue on your own. So that has to do with your presentation, to your clinic instructor. What should you say? 72-year-old male, controlled diabetes, controlled hypertension. This is what his vitals were today. These are the medications that he's taken, and he has taken them all this morning. This is all information that, in the event we have to call 911, they're going to want to know, did this patient take their medications? So asking, do you take your medication in the morning? Do you take it at night? And then documenting that on their medical history as well. So the ASA physical status classifications. We use 1 through 4. Statuses 5 and 6 are only in the hospital, and it basically, you're about to die. So we only focus on 1 through 4 in our clinic. Can it change? Of course. Say, you saw a patient in September, you're going to see them again in October. In the meantime, they got a sinus infection. They were put on antibiotics, and they broke out in hives and went into anaphylaxis. That's a change. That's going to change their ASA, because now they have that allergic reaction and those allergies. So make sure that you review and you're familiar with treatment modifications for each classification. They are always posted in the clinic on the whiteboard. If you have any questions, you can refer back to that. They're also located on your desktop within clinic, and your faculty is there to help you, especially this semester. Make your best educated guess and then walk through it with your clinic faculty. So the recognition of anxiety. So this is again what I was talking about before. Questions on the medical history, vitals. Are they sweating, dilated pupils, alert, stiff, fiddling or fidgeting? Their arms, you don't necessarily always see or usually see a patient sit in their chair and cross their arms across their chest. Look at their past history. Have they canceled a lot of appointments? Do they only usually come in when they have an emergency? And then we also try to get them set up for cleaning as well. So look into that because that's usually your anxious patient as well. Stress reduction protocol. So what is stress reduction protocol? So it's the recognition of a medical risk. We want to always when we're having stress reduction protocols, we want to take their vitals at the beginning, but we also want to take them at the end too to make sure that they're good to be dismissed. We're going to do a consultation as needed. Appointment scheduling, right? We're probably going to schedule them in the morning, maybe shorter visits. Then monitor, like I said, monitor and record vitals before and after. Anxiety control. How about pain control, right? So sometimes we might think, no, we won't do pain control because the administration of local anesthesia is going to make them more nervous. But actually, once they're numb, it might just kind of relax them because they're not feeling the instruments and things like that. So it might actually make the appointment more enjoyable for them. So pain control is definitely one. Shorter appointments, like I said, and then postoperative anxiety and pain control. So I will ask my patient at the end of, say, I did some scaling and root planing. I will talk about pain control. I'll let them know you may be sore, you may be tender in that area. Warm saltwater rinses, over the counter pain reliever. What do you usually take? Oh, I take Tylenol. Great. You might want to even just take some Tylenol before the anesthesia wears off. So then that will help control any bit of uncomfortableness they have. So a medical consult. So when is a medical consult needed? When we're unclear about any kind of risk to a patient. Are they going to, end up with an infection around their heart? Did they just have a joint replacement done? Um, but remember, it's not permission from the doctor to treat the patient. That underlying lining decision is your faculty and the doctor in the clinic's determination. The doctor might say, yeah, they had a heart attack last week, but no, they're fine. No, they're not. We have very specific protocol in place as to when we will be able to see that patient again, because someone that just had a MI or heart attack are more at risk of having another one. So that is why we delay treatment before seeing them again. I think, you're most at risk within the first week and then it goes down, but we have very specific timeline of when we'll see that patient. But and again, remember the final responsibility is yours and it's yours and your faculties. So use of drug references. So medications, like we said before, they're clues to patient conditions. So they might say, no, I'm fine, but I take this medication here. You look it up, you find out it's for high blood pressure. Oh, I see you're on high blood pressure medication. Oh, yeah, I guess I have high blood pressure. I've been on that medication for years. I don't even remember what it's for. So medications are clues. If a patient says they don't have their medications, it happens all the time. Oh, I don't know what I take. I take something for high blood pressure. I will usually ask the patient to find out what that medication is before proceeding with treatment, especially in the clinic, we will need to know what medications they're on. So even when confirming your patient, I like to say, please bring a list with you of any medications that you're currently taking. If it's a very long list, I'll have them give me that information beforehand. So then I can start looking up those drugs because the drugs may cause treatment modifications, they may affect treatment outcomes, and they may be the cause of the need for treatment. So there's medications out there that cause gingival enlargement. There are medications that cause dry mouth is a very common side effect in a lot of different medications. So we always want to look up what effects those medications may have and interactions as well. So when we are in the clinic too, we now have LexiComp on the computers. I know we started using it in pre-clinic. get comfortable with it because it's really great and it has some great resources and a great way to pull up drug information. Stay away from like drugs.com and those kinds and really kind of either use Lexicomp or we have the Mosby's books in the clinic. Those are going to give you the best information. So now let's talk about drug names, right? So we have the chemical name, the generic name, and the trade name. So the chemical name is the super long name. Like when a drug hits the market, say from Moderna, Pfizer, something like that, they have this really long chemical name. Generic name is the name of the medication, and then the trade name is it's not the same as brand, but we use it interchangeably. So trade, think brand. So think, acetaminophen and Motrin. That would be your generic versus your trade or brand name. Excuse me, acetaminophen and Tylenol. Ibuprofen is Motrin. So let's look at the drug names. So generic, again, acetaminophen, Tylenol. Do you see any difference? Not so much. There is some research that's coming out now that some trade name drugs may be better than the generic. Again, you're not going to see that with Tylenol and acetaminophen or anything like that, but the drugs that are used to treat, it could be a drug for epilepsy. You might find that there's less side effects with the trade rather than the generic. But again, it's just research coming out. So I really don't have any more information on that for you. So again, Mosby's dental drug reference, you'll find those on the clinic floor. They have good information geared to dentistry. You look the drugs up alphabetically by their generic name. So if you have a trade name for a drug, you can Google the trade name to get the generic name, and that's where you'll find it in Mosby's. And that's the end.